I am going to be talking about Aspergillus-related lung disease today. I have no relevant conflicts of interest or disclosures relevant to this talk. I'm going to start with an introduction, review the spectrum of Aspergillus-related lung disease, touch on some important diagnostic considerations, and then delve into more depth, particularly about allergic bronchopulmonary aspergillosis, and then also briefly review chronic cavitary pulmonary aspergillosis and invasive pulmonary aspergillosis. Given it's July, we have new trainees, things like that. I think it's good to overview all of this as it's something that comes up quite often as a diagnostic consideration, differential consideration on the consult service. So Aspergillus is a genus of mold with over 250 species. It's found throughout the environment, particularly in soil and decaying organic material. Essentially anything where there's organic material and water, you can get Aspergillus. It's not the most prevalent mold worldwide, but it's the most ubiquitous with airborne conidia. Conidia are the asexual non-motile reproductive spores or the fungal dust. You can see this picture here highlights all of them. Everyone inhales hundreds of these Aspergillus conidia daily, but whether or not that actually leads to disease depends on the host immune system. Aspergillus can affect the lungs in many different ways. One bucket kind of category system that I like to put this in is the level of invasiveness. So you can have non-invasive disease, which would be your aspergilloma, used to be called mycetoma. Those are the fungal balls in the cavities. You can see a nice illustration here of a fungal ball in a chronic cavity that was present in someone's lung. Allergic bronchopulmonary aspergillosis, which we'll talk in more detail briefly. You can get semi-invasive disease, which is chronic cavitary, which can progress to fibrosing pulmonary aspergillosis. And then you have your invasive disease, the classic example being invasive pulmonary aspergillosis in your stem cell transplant neutropenic patient with the nodule surrounding ground glass. You also get trachobronchial aspergillosis, which looks like ulcerative lesions and pseudomembranes in the trachea, particularly most common in lung transplant recipients. And that's important to recognize because it can lead to dehiscence from the lung transplant. Another bucket is the level of acuity in terms of how long it's been going on, with acute being invasive pulmonary aspergillosis, to some subacute forms to chronic pulmonary aspergillosis. I really like this figure that was published by Danielle et al. In the European Respiratory Journal back in 2016, because this Venn diagram, I feel like, really highlights how often these chronic pulmonary aspergillosis manifestations overlap and multiple can be present in the same patient. When you're considering whether or not someone has true pathogenic aspergillosis, there's some important things to take into consideration. Aspergillus does grow on routine culture media, but you get better likelihood of recovery with a fungal specific culture media. I think it increases the recovery percentage by 30 or 40%. That said, just because someone has a positive culture doesn't mean that it's pathogenic, particularly from non-sterile sites, including the airways. Colonization is common even at patients that have risk factors for aspergillosis. There are a couple of tests that we tend to send for this. One, to help sort this out. One is galactomannan, also called Aspergillus antigen. In EPIC at Michigan, it's Aspergillus antigen. That is a polysaccharide antigen that's primarily in the cell walls of Aspergillus species mold. The sensitivity of that really varies depending on the host's immune system. So up to 90%, but in some cases only 44%. Better sensitivity in neutropenic patients, and you also get better sensitivity in BAL samples versus serum samples. Important caveats to this: you can get false negatives, particularly in patients that have non-traditional risk factors or have recently been treated with antifungal therapy, and you can get false positives, particularly in the ICU patient population, for patients that are being treated with piperacillin tazobactam or amoxicillin clavanolate. Fungitel or beta-glucan is another test that's often used. It's non-specific, meaning, a lot of other fungi produce beta-glucan. It's a cell wall component. It's in Canada, it's in pneumocystis, but if it's negative, it has a very high negative predictive value. PCR, if that's available for you, also has a modest sensitivity, but a high negative predictive value. company in the Netherlands that's working on a couple different nucleic acid-based assays, but that's not yet available for prime time. So delving more into allergic bronchopulmonary aspergillosis. So this is an IgE-mediated hypersensitivity response to persistent Aspergillus fumigatus in the airways. It's indolent, sometimes progressive disease. It happens year-round, and there's been some studies looking at whether the ambient spore count affects things, and unfortunately, no kind of correlation with increased incidence if there's higher spore counts. No gender predilection. Most commonly seen in asthmatics and cystic fibrosis patients that also have atopy. That said, there's been increasing recognition that this can happen in other lung diseases, even though the diagnostic criteria, which we'll get into, haven't really caught up with this. So you can get it in non-cystic fibrosis bronchiectasis, patients with asthma and COPD overlap. There also was a study that looked at patients that had both COPD and bronchiectasis overlap and found that there was increased frequency and severity of ABPA compared to those that just had COPD or bronchiectasis. Presents with new worsening cough, increased sputum production, mucus plugs, wheezing, hemoptysis, kind of non-specific pulmonary symptoms. You can get constitutional symptoms like low-grade fever, malaise, fatigue, weight loss. One of the triggers that causes me to consider ABPA is particularly if someone is having hard to control their underlying pulmonary disease, or they were well controlled before and something's changed, but they're still adherent with all of the treatments we had previously done. Get bronchiectasis with restriction and decreased diffusing capacity, and some patients do develop fixed airflow obstruction. There's some classic radiographic findings. So on this image here is an example of the finger and glove or gloved finger sign. So these are essentially very dilated airways that are filled and totally opacified with mucus. You can also get hyperattenuated mucus here. And so this is this increased white here. And so that's defined as Hounsfield's units greater than 70. And this speaks to the chronicity of the mucus impaction. The longer it's there, the more iron and calcium and manganese that deposits into that mucus, leading to that hyperattenuation. You can get these very varicose and more central bronchiectasis and some more hyperattenuation here. Sometimes patients will have what a lot of the literature calls fleeting parenchymal opacities. And so what that is it's not actually, airflow alveolar issues. It's more atelectasis, mucus plugging, sometimes lobar collapse that leads to these opacities that tend to move around. This is an example of more severe ABPA where you can have pretty dilated cystic bronchiectasis through here. You can have mucus plugging and tree and bud nodularity. So as I mentioned before, ABPA kind of tends to present, at least classically, in patients with asthma and cystic fibrosis. In patients with ABPA and asthma, it's unclear whether the asthma itself is a risk factor or whether these two disease processes share a common predisposition. There was a very small study of 11 patients with asthma with ABPA, and 8 of the 11 had CFTR heterozygous mutations, which is obviously a higher rate compared to what we would expect in the general population. So there's some thought that maybe CFTR mutations contribute to the pathogenesis. About 25% of asthmatics are sensitized to Aspergillus. About 2% of those actually have ABPA, leads to difficult to control asthma, particularly productive cough with nasty brown mucus plug. The Infectious Disease Society of America actually recommends screening with annual Aspergillus fumigatus specific IgE levels in asthmatics every year. This is not something that I actually see in clinical practice. I know my own practice is really, I send this if I'm noticing that the asthma is harder to control and I want to make sure I'm not missing something else, but I don't send it every year in every asthmatic. That said, maybe I should be better about doing that because there is data that ABPA is underdiagnosed. 7 to 14% of corticosteroid-dependent asthmatics met diagnostic criteria. In cystic fibrosis, it can be hard to pin down the diagnosis, and I'll delve into that a little bit more. But in general, based on some of the cohort studies of ABPA and cystic fibrosis, increased prevalence if they're male, adolescents, lower lung function, if they have Pseudomonas in their sputum, if they also have a history of wheezing or asthma. There is some recommendations for screening annually from age 6 or with clinical change. I don't see cystic fibrosis patients personally, but I'd be interested to see with my CF colleagues whether they're actually doing this screening annually or if it's more just kind of if there's change in symptoms. Patients with cystic fibrosis and ABPA do have a greater decline in function and potentially worse than bronchiectasis compared to those without. So diagnosing ABPA has evolved over the past couple of years. In the past, it used to be based off of the Rosenberg-Patterson criteria that was developed in 1977. Then there was this International Society for Human and Animal Mycology, a working group that developed a diagnostic criteria in 2013. They most recently revised this in 2021. And so this is the diagnostic criteria I see most used currently. It does require the presence of asthma. You have to have an Aspergillus specific IgE greater than 0.35 and a serum total IgE greater than 500 international units per milliliter. And I do want to draw people's attention to the units there, depending on where you practice, what lab you're at. There's different units that are used to report these lab values. And so it can lead to misinterpretation of the results. So some places report nanograms per milliliter for the total IgE. One international unit per milliliter is 2.4 nanograms per milliliter. And to add to the confusion, actually at our lab, we don't report in either of those values. We report in kilounit per liter, but that's actually equivalent to international units per milliliter. So you have to have asthma and those 2 serologic markers, and then you have to have at least 2 other consistent findings. So positive Aspergillus fumigatus specific IgG. And for that, the specific cutoff value, again, varies by population. In India, they use 2.4. In the UK, they use 0.4. So that does vary. So check with your specific lab for that. Bronchiectasis on CT chest and peripheral blood eosinophilia. And for the fellows and new trainees in the audience, when you're looking at our cell counts with differential in our lab, it's reported in kilocells per microliter. So whatever's reported in our lab, that number you have to multiply by 1,000 to actually get the cells per microliter. So you might think it's not elevated when actually it is. The advantages to this ISHAM diagnostic criteria is that it did take into account a lot of the limited evidence, granted, and does have clearly defined cutoff values. It was evaluated prospectively, and you can diagnose ABPA without someone already having bronchiectasis. That said, it's only studied in asthma patients, and it's not known if it's really applicable in cystic fibrosis patients. Second diagnostic criteria that has come up recently was published by Asano et al. In 2021. Very similar criteria in terms of blood markers, looking at IgE levels, peripheral blood eosinophilia. This one also includes whether or not there's any filamentous fungal growth on sputum or BAL, and looking at high attenuation mucus. And the nice thing about this diagnostic criteria is you don't have to have a formal diagnosis of asthma. You just have to have some sort of asthmatic symptoms. It also is not limited to Aspergillus fumigatus specific findings. There is a allergic bronchopulmonary mycosis, so similar syndrome, but to other fungi or other species of Aspergillus. So one of the advantages of this diagnostic criteria, you don't have to have asthma and you can use an ABPM. And it was also evaluated in a cohort of Japanese patients. Disadvantage, again, not known if it's applicable in cystic fibrosis patients. Some of the criteria you do need bronchoscopy or BAL to look into. And there is a high false positive rate of what they define as probable ABPA. So for ABPA, you had to have 6 or more of the listed criteria. For probable, 5 of 10, but that had a very high false positive rate. As I alluded to before, diagnosing ABPA and cystic fibrosis is challenging. As you can imagine, cough, wheezing, increased sputum, worsened spirometry, decreased exercise tolerance. We see all of those in cystic fibrosis exacerbations. So the Cystic Fibrosis Foundation Consensus Conference criteria that was published back in 2003 and hasn't been updated for a while, they look at essentially the acute or subclinical deterioration and then add some additional blood work there. There is a higher serum IgE cutoff than the asthma criteria, greater than 1,000. And you have to see some worsening on CT scan with new mucus plugs or infiltrates there. How do we treat ABPA once we diagnose it? So the overall goal is to induce remission by suppressing inflammatory pathways with minimal side effects. This is the mainstay of treatment is systemic steroids. There's been some small studies that looked at using inhaled corticosteroids that on their own, which didn't lead to much benefit. So steroids by pill to decrease inflammatory response to Aspergillus. Optimal duration is unclear. We'll get into dosing and duration with a randomized control trial that I'll talk about in a little bit, but patients are on decently high doses of steroids for several months. Antifungals are also used. Typically, azoles is the class. This leads to decreased antigen burden and decreased immune response. This is not typically used for monotherapy. The guidelines currently recommend if someone is, treated with acute ABPA to start with steroids, they're having an exacerbation or hard to wean off the steroids to add itraconazole to help wean for that. That said, I would imagine in the future that we will be reaching more for antifungals as first line. There is a small study that looked at itraconazole versus prednisolone monotherapy, and patients, there was less remission, but 80% of patients did achieve remission with less side effects with itraconazole. So larger studies needed to look at that, but that may be something down the line. In refractory patients, omalizumab or Xolair has been used. This is mostly still in the case reports. There hasn't been a clinical trial to look at this yet. Xolair is humanized monoclonal IgG antibody that inhibits IgE binding to the IgE receptor on mast cells and basophils. So it makes sense why this would be helpful because IgE is extremely elevated in that whole inflammatory cascade for ABPA. So out of the limited data that we have for ABPA, there is a randomized controlled trial looking at 2 different steroid dosing regimens in asthmatics. This is a single center study out of India. Were randomized but not blinded. It consisted of 92 treatment naive patients. So this is first diagnosis of ABPA, and they were randomized to either receive high dose steroids, which was defined as prednisolone at 0.75 mg per kg daily for 6 weeks, followed by a taper over several weeks, and total steroid therapy of 8 to 10 months versus a medium dose that started at a lower dose at 5 mg per kg for 2 weeks and tapered much more rapidly with total steroid duration of about 3 to 5 months. The 2 groups were evenly matched in this study. Average age was 31, a little bit more men, had asthma for about spirometry, and FEV1 was less than 60% in 40% of them. 72% had bronchiectasis, and there was high attenuation mucus, and all of them were at least on ICS-LABA for treatment of their asthma. When you look at their primary outcomes here, you can see that they were looking at the number of exacerbations after 1 year of treatment and whether they were steroid-dependent ABPA after 2 years of treatment, and there was no difference between the high-dose group and the medium-dose group. But there was significantly less steroid in the medium-dose group and significantly less weight gain and other steroid side effects in the medium-dose group, and there was no difference within the time to first exacerbation. So based off of this single relatively small study, they do recommend more of a medium dose steroid protocol with a change to higher dose if they're not responding as expected, which to me would also raise the question of, is it truly ABPA if they're not responding to the steroids and looking into other potential etiologies of their symptoms. A little more detail about the antifungal agents specifically used in ABPA. Itraconazole is the first line, and again, steroid sparing if corticosteroids alone are ineffective. There have been some small studies looking at using posaconazole or voriconazole. Voriconazole has greater bioavailability with oral intake, where itraconazole can be difficult with dosing and absorption. Optimal duration of these are not well defined. There are adverse effects with it. And the most important thing to consider, particularly with itraconazole, is it's a very potent cytochrome P450 inhibitor. And so there are multiple drug-drug interactions. The ones that are most relevant to us as pulmonologists is there have been reports of patients that are receiving both inhaled budesonide and itraconazole, or inhaled fluticasone and itraconazole, actually developing increased systemic absorption of the steroids to the point that they get Cushing syndrome. Other drugs can have interactions with methylprednisolone and dexamethasone, but not prednisone. In the future, I think we're going to start seeing more anti-Th2 directed therapies, particularly the asthma biologics that we're getting more comfortable with. Currently, these are all case reports, but there are some ongoing clinical trials. The current recommendations are to reserve these for patients who have uncontrolled asthma or significant adverse effects. How to monitor for recurrence of ABPA and exacerbations, because it does tend to exacerbate over time, is a bit of a debate. Essentially, monitoring IgE levels for looking for increase in dose is what most people recommend. There is Aspergillus fumigatus specific IgG is good for diagnosis, but it doesn't really vary based off of monitoring for treatment response. So that's not recommended. So now I'm going to shift focus a little bit and talk about some other manifestations of Aspergillus-related lung disease. So chronic cavitary pulmonary aspergillosis. This is the most common form of chronic pulmonary aspergillosis. Mostly happens in immunocompetent patients with underlying structural lung disease. So these are our COPD patients that have significant emphysema, our sarcoid patients that have, cavities and fibrotic sarcoid, those sorts of things. It can progress to chronic fibrosing pulmonary aspergillosis if it's untreated over time. It does have decent mortality rates with it. If it's untreated, 50% within 1 year and up to 75 to 80% at 5 years. I wonder if part of this is just reflecting of not just the underlying issues with the pulmonary aspergillosis affecting the cavities, but also reflective of the underlying structural lung disease as well, contributing to that. With antifungal therapy, there is an improvement in mortality at 5 years. Patients present subacutely. They must have symptoms for more than 3 months. Tends to be nonspecific again, cough, chest pain, small volume hemoptysis. Constitutional symptoms with fever, night sweats, and weight loss. The diagnosis is, again, you have to have at least 3 months of symptoms, and you have to have cavitary lesions on imaging with either pericavitary infiltrates, new cavity formation, or increasing cavity size. A positive Aspergillus-specific IgG antibody is really great. If that's positive, that helps differentiate someone who's just colonized with Aspergillus versus someone who's actually infected. That says the antibody titer is not reflective of the extent or severity of disease. So it's kind of a yes, no, not a gradation. Have to have no invasion of the hyphae into the parenchyma. Otherwise, that would be invasive pulmonary aspergillosis. And you have to exclude other pulmonary pathogens and etiologies. Chronic cavitary pulmonary histoplasmosis or coccidiomycosis can look very similar to this, but the antifungal that you would use would potentially be different in that situation. Patients often have mycobacterial infections that are either co-infections or may happen before or after CCPA. And then you have to also consider your differential for cavitary lung lesions in general. Is this a necrotizing lung cancer, pulmonary infarct? Do they have vasculitis? Those sorts of things. When you're working this up, culture positivity up to 81%, but it's still a significant number of patients that don't have positive cultures. And so again, the Aspergillus IgG, and then the galactomannan can also help add additional, if it's positive, can help add additional certainty that this is what's going on. So here are two different CT scans from two different patients, highlighting some classic radiographic manifestations of chronic cavitary pulmonary aspergillosis. You can see a large, very thick wall cavity here, and you can see inflammation, some ground glass surrounding the cavity here. This cavity, again, larger, thickening through here, and you can even see some fibrosis as well as some other pulmonary nodules here. How do we treat it? So antifungal therapy, again, itraconazole or voriconazole are the preferred agents. There have been case reports of using percutaneous installation of antifungal agents directly into these cavities. That said, there's also complications, including potential air leak, all sorts of things like that, pneumothorax. And so I've never actually seen that done, but there's case reports of that. In general, we want to treat if there's decline in lung function, radiographic progression, symptomatic hemoptysis. Most of these patients are symptomatic when we find them. And so I find that they, because we're doing the imaging to figure out why they're symptomatic. And so I find most patients are treated. Patients are on antifungal therapy for at least 6 months. Oftentimes they're on for at least a year. It's unclear how long to treat for. Some patients may need indefinite suppressive therapy, particularly if they're going to be immunosuppressed for, management of their sarcoidosis, or if we can't get them off steroids for their COPD, some of these other things that increase the risk of it coming back. In cases with localized cavities, having significant hemoptysis, you can consider surgical resection if the patient is a surgical candidate otherwise, or bronchial artery embolization. Surgeons take a slow hand at resecting these cavities. They can lead to bronchopulmonary fistulas, persistent air leak, wound infection, persistent disease in the pleural space, and there's higher complications than those with multi-cavity disease. So it's not low risk to go in and resect these cavities. Now touching on invasive pulmonary aspergillosis. So this is, as opposed to the other two, ABPA and chronic cavitary pulmonary aspergillosis, this one is when the aspergillus actually directly invades the lung parenchyma, trachea, or airways. This most commonly, we think about it in transplant patients, whether it's solid organ or stem cell transplant. It has a high mortality of about 22%, higher in non-neutropenic patients, probably because there's a delay in diagnosis in that patient population. Diagnostic definitions are only validated for neutropenic patients. So even though non-neutropenic patients can get this, it just really hasn't been studied well. Risk factors for developing invasive pulmonary aspergillosis are severe or prolonged neutropenia, defects in cell-mediated immunity, transplant, as I mentioned before. Lung transplant is the highest risk out of solid organ transplants. ICU patients actually are at increased risk, and this is thought because you're often getting patients that are with severe COPD that are on steroids, or they have structural lung disease, ARDS, impaired mucociliary clearance after infection. Viral infections also predispose to risk, particularly influenza, RSV, and COVID. And this is thought because there is epithelial injury within the airways that then allows for invasion by Aspergillus that's already colonizing the airways. Other risk factors are patients on immunosuppressive medications, particularly those that have stem cell transplant with graft-versus-host disease, and then they're getting immunosuppressed in the setting of that. That's a very high-risk patient population. Patients with TNF-alpha blockers or TKIs like dasatinib or imatinib, there are pretty high rates as well with that. There's also some genetic determinants with this. There was a small study looking at that found polymorphisms within the genes that encode pentraxin 3 and toll-like receptors 2 and 4 had increased risk for developing invasive pulmonary aspergillosis in patients that had stem cell transplant or solid organ transplant. How it manifests is fever, cough, dyspnea, and then signs of angioinvasion. So chest pain or pleuritic pain, hemoptysis. Patients are often profoundly immunosuppressed, so sometimes there can be less symptoms due to a lack of an inflammatory response. This picture here is a classic example of invasive pulmonary aspergillosis, where you have a large pulmonary nodule surrounded by ground glass, which is, the halo sign, and the ground glass is, pulmonary hemorrhage from the angio invasion. You can also sometimes see reverse halo signs. You can get multiple solid or solid pulmonary nodules or masses with or without cavities. And in some aggressive advanced cases, there have been direct invasion of the aspergillus into adjacent chest wall or mediastinal structures. Highlighting a little bit more the COVID-19 associated pulmonary aspergillosis. So as I mentioned with the viral illnesses, damage to the epithelium leads to dysregulation and impaired ciliary clearance, and colonization of the aspergillus then leads to tissue invasion. Higher risk because they're often receiving immunomodulators as part of their COVID treatment, such as, Decadron or tocilizumab or baricitinib. Variable incidence with this, and it's kind of hard to study given there's so many other confounding factors that are going on in patients that are, with COVID, particularly if they're in the ICU. But some things to think about to consider COVID associated pulmonary aspergillosis is if there's refractory or new fever, hemoptysis or chest pain in pleuritis in these patients. Again, challenging to diagnose, hard to do a bronchoscopy given, risk of aerosolizing COVID, and sputum cannot rule out colonization. Aspergillus antigen or galactomannan greater than 1 on a BAL sample can be helpful for that. But it's important to have a low threshold to consider this because there is some early data showing that treatment as soon as possible improves outcomes in this already at-risk patient population. How do we treat it? First line is voriconazole. There also is some movement lately to use isavuconazole, given that has less side effects and less drug interactions. But the guidelines still recommend voriconazole. In salvage therapy, adding additional antifungals, you can consider surgical resection depending the site. There is an active study going on looking at using both triazoles and echinokindins to double treat from different mechanistic pathways to see if there's improvement. Minimum duration of treatment is 6 to 12 weeks. One important consideration is that resistance to azoles is increasing, and this is in part because this invasive pulmonary aspergillosis tends to happen in a patient population who is already being prophylaxed for fungal infections. They're on posaconazole to help prevent this from happening. And so the patients that are getting this are more likely to have resistance to azoles in general. There was some studies, depending on the location, that the in vitro resistance was up to 6% in the UK and Netherlands. US resistance patterns is about 4%, but in some areas of India, it's up to 20%. With that in mind, there are some other treatment modalities or that are being actively investigated. The two that I want to highlight based off of this slide is opilconazole. And so this will be interesting because it is a inhaled triazole. And so the hope is that we can get higher concentrations of the antifungal down into the airways without some of the systemic effects or as much drug-drug interaction. That's not going to help so much with the azole resistance because it's an azole itself. The other one is rezafungin, which is a kind of candid, but it's designed to be dosed once weekly. So some of these patients, would be able to potentially get this as outpatient therapy instead of being stuck in the hospital for their micafungin infusions and things like that. So this was kind of an overview whirlwind of Aspergillus-related lung disease. Some key points that I want to make sure to point out is that Aspergillus lung disease ranges from acute to chronic, and there's varying levels of invasiveness. Determining colonization versus infection is challenging, and the criteria to diagnose infection depends on host factors and the specific Aspergillus-related disease of concern. Galactomannan has varying sensitivity and but it's higher in neutropenic patients and with a BAL source. Fungitel is nonspecific, but a good negative predictive value. ABPA is a hypersensitivity response to persistent aspergillus in the airways, particularly in patients with asthma and cystic fibrosis, but should consider it in other disease processes if they're presenting with concerning symptoms. We reviewed the diagnostic criteria and then for ABPA, and the mainstays of treatment are steroids and azoles with consideration of omalizumab. Chronic cavitary pulmonary aspergillosis, patients present with subacute symptoms with high mortality rate if untreated and requires months of antifungal therapy. And there's risk factors for invasive pulmonary aspergillosis include prolonged neutropenia and respiratory viral infections and increasing recognition of other risk factors, including ICU time in this patient population, and early treatment for COVID-associated pulmonary aspergillus improves outcomes. And there's multiple new antifungal agents actively being developed. So that's my talk for today. Does anyone have questions about that? I know I talk fast and I went through a lot of different things, so I'm happy to delve into anything in more detail if that would be helpful for anyone.
Do you know if Cresemba is better being covered as outpatient? It had previously been pretty expensive.
Oh, that's an excellent question. I'm actually not sure. It's been a little bit since I've tried to get Cresemba approved personally, but that's definitely often a hurdle. Okay, great. Well, thank you everyone for coming to my talk. Feel free to reach out if there's any questions via email or anything else that I can help with. Otherwise, enjoy the rest of your day.